which has been given to me, the introduction to ECG, is again one of those topics which is particularly interesting for the family physicians, because this is one of those technologies which is appropriate to our environment of low-tech activity. Unfortunately, many times it is thought that this is something perhaps only for the cardiologists or the specialists. But in fact, with a very little effort, one can get a lot of useful and vital and life-saving information from ECG. So my talk will be primarily directed to the ECG utility in a family practice setting. And I won't go into too much intricate details and interpretations of electrocardiographic basic topics. And next one. The electrocardiogram or graph, as we all know, is the electrical activity of the cardiac contraction. It was first named as EKG by Einthoven in 1983, and he was awarded the Nobel Prize in 1924. That should be 1883. That's a misprint. This one? Right. And he did a lot of work to actually develop and improve the ECG. The 1993, the leads, they were increased from 12 to 15. So far we usually take 12 lead ECG, but since 1993 they have been increased to 15 to give it a more reliable interpretation and sensitivity to pick up ischemic heart disease. But we will be mainly discussing the 12 lead ECG, which is the standard practice all over the world. Next one. Now that's the man, and that's his machine. The whole thing was the ECG in the early part of the last century. Next one. Now he introduced the concept of Einthoven Triangle, that the heart is in the center there, and we can pick up the electrical activity. Initially, he discovered the lead 1, 2, and 3 as the difference of electrical potential between the right and the left arm, between the right and the left leg or foot, and the third, the left arm and the left foot. Now, these were called the standard bipolar limb leads, and that is lead 1, 2, and 3. Later, as I mentioned, the unipolar leads were discovered in 1933, and they were from the right arm, and left foot, called AVR, AVL, and AVF. And subsequently, chest leads were introduced V1 to V6. So that makes it the 12 lead ECG. Next one. Now, we'll have to, I think, cut down the light if possible. That's better. Now the 12 lead ECG consists of lead 1, 2, and 3, AVR, AVL, and AVF, and V1, V2, V3, V4, and V5, and V6. And we usually have a long strip of lead 2 at the bottom for the rhythm. Next one. Now, what do we expect from the ECG? The clinical diagnosis, we must realize, mainly depends on the history. To a lesser extent, on physical examination. ECG, like all tests, is a tool to support the diagnosis, but is not the only way of making the diagnosis. We must be very clear about that. However, it is sometimes crucial in making a diagnosis and also in the management of the patients. Next one. There are basically two approaches to interpreting the ECG. As I mentioned, we can either make a scientific analysis of the tracings on the principles of electrical conductivity. That's a time consuming and little difficult, but that is the more appropriate and exact approach. But an average practicing physician or a doctor or a family physician doesn't have to learn all the electrocardiographic principles to interpret the common problems which we encounter every day. So I would choose the second approach, that is the pattern evaluation approach or the pattern reading, rather than going into the basic electrophysiological principles of ECG production and its analysis. Next one. The crucial role of the ECG in the diagnosis is in the management of chest pain. Is very important instrument. Cardiac arrhythmias, predicting sudden cardiac death, cardiac hypertrophies and strains, electrolyte and metabolic disturbance, drug effects, advanced cardiac life support. Next one. In chest pain, we are basically concerned that whether a person has got ischemic heart disease or whether it's a pericarditis or a pulmonary embolism or is one of those many other causes of chest pain which are non-cardiac and non-pulmonary. And this is an area where ECG is particularly helpful and easily available these days. Next one. I think we'll have to cut down the light, and if we can cut down this one also, maybe that will improve the visibility. Now the normal ECG is shown here, and we can see that the ST segment is isoelectric, whereas on this side we find that the patient has ST segment elevations. Now that is the normal versus the interior myocardial infarction. Next one. Now in the inferior myocardial infarction, we find that the ST segment elevations here, they are in the inferior leads, that is 2 and 3 and AVF, and not present. But you see that the ST segment is depressed in the lead 1 and 2. Next one. Now, in addition to the ST segment elevation myocardial infarction, where eventually Q waves will appear, we find that the type of myocardial infarction which does not produce ST segment elevation is an entirely distinct entity. So when we find that instead of ST segment elevations, there are only T wave inversions or ST segment depression but no Q waves or ST segment elevation, this is a type of patient with infarction where thrombolysis is not indicated. So not only it helps in the diagnosis, it also helps in the type of the treatment you would like to give to the person. Next one. Now coming to the acute pericarditis, again we find that patients with acute pericarditis also have ST segment elevations. Here, for example, most prominent in V5 and V6, but to some extent in other leads also. And lead 1 there. Now the important thing is that this ST segment elevation has to be distinguished from the ST segment elevation of myocardial infarction. Unfortunately, the tracing in the infarction was not so clear to show you, but the fundamental difference is that here the ST segment elevation is concave upwards and is not associated with corresponding depression in the opposite lead like lead 3 or in lead AVF. They are both elevated. Similarly, the ST segment elevation in V5 and V6 is not associated with any depression in lead V1. This is called a concordant ST segment elevation, that all leads, they show the elevation in the same direction. Whereas in myocardial infarction, what we would have found was that in lead 1 the ST segment elevation would be associated with ST segment depression in lead 3 or lead AVF. Similarly, V5 or V6 ST segment elevation would be associated with depression in V1. So the ST segment changes are opposite on the opposite leads in myocardial infarction. That is one difference, and that is called a discordant ST segment change. Whereas the concordant ST segment change on the same direction, like in pericarditis, is called the concordant change. So although there is ST segment elevation, but the nature is different. And secondly, as you can see that this is concave upwards rather than the convex upward in myocardial infarction. Next one. Now in pulmonary embolism also the ECG can be very helpful, and here we find that the typical change of pulmonary embolism is a deep S wave in lead 1 and a Q wave in lead 3, and similarly an inverted T wave in lead 3. Now this is called S1, Q3 and T3 phenomenon, and this is associated with a tall R wave in V1. That is suggestive of an acute pulmonary embolism. If one has a previous ECG available and one finds that these changes have appeared recently, that is absolutely typical of a person with pulmonary embolism. But even without that, this would be highly suggestive. Next one. The second area where ECG can be very useful is the prediction or evaluation of the future chances of a sudden cardiac death. Now, cardiovascular disease is the commonest cause of death, as we know, and 50% of these deaths, they occur suddenly even before the patient reaches the hospital. Majority of these are due to arrhythmias, and most of them from ventricular tachycardias going on to ventricular fibrillation. Next one. The commonest cause, as we mentioned, is ischemic heart disease, which accounts for 80% of the cases. In about 10 to 15% of the cases, cardiomyopathy may be the cause, and in about 5% of the cases is uncommon conditions like primary electrical and genetic ion changes, abnormalities, or valvular or congenital heart disease. Now this is the sequence of events that shows the normal sinus rhythm. It changes to ventricular tachycardia and eventually ventricular fibrillation. Now ventricular fibrillation means technically, clinically, the death of the person unless it is reverted within 3 minutes. Next one. The mechanism of sudden death is given here, but I think we'll skip that. Next one. The indicators of high risk, which I mentioned, is the main aim that how the ECG can help us to predict or to find the prognosis of the chances of sudden cardiac death. Presence of left ventricular hypertrophy, presence of a polymorphic ventricular tachycardia, I'll show you, a long QT interval, presence of WPW syndrome. These are the typical ECG changes which can predict a future chance of high degree of sudden death. And this type of patients having these electrical ECG abnormalities should be investigated beforehand, because their chances of getting a sudden cardiac arrest are very high. Next one. That just shows that in the general population we have that much incidence of sudden death, whereas in persons who have ischemic heart disease evidence, the sudden death is almost 30% chance in the next 5 years. We find that although the incidence in normal population is very low, but majority of the deaths will occur because of it, because of the large number of normal people, whereas this contributes to very little. Next one. Now, which are the arrhythmias which can cause sudden cardiac death? Ventricular fibrillation is the usual cause of sudden death in majority of the patients, and that is the picture on the ECG. It is usually preceded by a ventricular tachycardia, and that is the picture of a ventricular tachycardia. But when it goes into this irregular type of complexes, that indicates fibrillation. And as I mentioned, at this stage must be treated immediately. Next one. Now, ventricular fibrillation requires immediate defibrillation, and if one can do it within 1 minute, then there is no need for any cardiopulmonary resuscitation. If 1 minute has passed, then basic CPR should be done first, and then person should be defibrillated. Next, and that's the technique for doing the defibrillation. This perhaps may be not feasible in majority of the family settings, but the possibility that a person who is defibrillating can survive, because the heart may be quite capable of continuing supporting life later on, and it's only the electrical disturbance which is causing the death, is a reversible phenomenon. Next one. The ventricular tachycardia originates in the ectopic foci in the ventricle, and that is the shape of the ventricular tachycardia. Broad QRS complexes and irregular shape of the QRS, and eventually it degenerates into fibrillation, where the irregularity becomes more marked. Contrast that with the normal sinus rhythm. That's the normal rhythm, and that is the tachycardia and the fibrillation. Next one. Now, one other ECG sign which should alert us to the possibility of a serious consequences is when a premature extrasystoles, they occur on the T wave of the subsequent QRS complex. If a QRS complex is to fall on this T wave as a result of an ectopic, and the ECG can show that those PVCs or premature ventricular contractions which tend to occur close to the T wave, they would result in eventual ventricular fibrillation in a very high percentage of the cases. Ordinary PVCs are not very dangerous. Normal people can have them. But when they have this R on T effect, that should alert us the possibility of serious nature of these changes. Next one. Now, ventricular tachycardia, if the person is pulseless, we have to defibrillate them. If pulse is present but the patient is unstable, then synchronized cardioversion is required. Now, long QT interval predisposes to a more serious form of ventricular tachycardia called Torsade De Pointes, which is always treated by cardioversion. The monomorphic type of ventricular tachycardia is a stable patients can be treated with drugs which can be used in the general practice also, and the drugs are particularly useful are the quinidine, procainamide, and in the case of ventricular tachycardia, we should not use the calcium channel blockers or the beta blockers which are used for the supraventricular tachycardia, which I'll show you later. Next one. Now, another thing which the ECG can help to pick up, which would indicate an eventual likely possibility of sudden cardiac death of a very high incidence, is this condition LQTS, the long QT syndrome. Now this is the QT segment, beginning of the QRS to T. Now in this area, the QT has a duration which is usually less than 0.44 milliseconds, which comes to less than half of the distance of the between one R wave and the other R wave. If this is prolonged, that makes the chances of any extrasystole occurring on the T wave more likely, the R on T phenomenon we mentioned. So this we can pick up from the ECG. Now here is a normal tracing with a normal QT. Compare that with the second tracing here, where the QT is more than half of the RR segments, or more than 0.44 seconds in duration. This is the long QTS syndrome. Now this is usually the result of congenital abnormalities in the ion exchange channels in the myocardium. But it can also develop secondary to drugs like quinidine and beta blockers and procainamide. So the same drugs which we use for the treatment of ventricular tachycardia at times may be predisposing them to the development of the possibility that QT may be prolonged and they are more vulnerable. That is why the interest in anti-arrhythmic drugs has become less, except when it is a monomorphic type of ventricular tachycardia, and the electrical cardioversion defibrillation is more reliable in these cases. Next one. Now that is the effect of the long QT interval, a form of ventricular tachycardia which you see sometimes it is downwards complexes, sometimes it is upward complexes. It rotates on its own axis. This type of ventricular tachycardia is given the name of Torsade De Pointes. So if we find either a long QT interval or a tracing like this of a ventricular tachycardia which is rotating on its own axis with the period of time, this is far more serious than the ordinary ventricular tachycardia. Next one. Now, third category where ECG can be very useful in predicting the serious outcome and chances of preventing them are the various types of familial disorders, particularly hypertrophic obstructive cardiomyopathy, a rhythmogenic right ventricular hypoplasia, a condition called Brugadas Syndrome, and Timothy syndrome. Here, the lesson to learn is we must ask for a family history of sudden death in the relatives in the past, particularly at young age. If that is present, those children or those adolescents must be investigated, and if they show the suggestive ECG signs, then it becomes all the more imperative. And I'll give you a few examples of that. Next one. Now that is the hypertrophic obstructive cardiomyopathy, where the ventricle is markedly hypertrophied in an asymmetric way, and particularly the septum is markedly hypertrophic. Now this results in the left ventricular outflow obstruction, which is of a dynamic nature, is not fixed. These are the children which very often die suddenly in the adolescence. They may be otherwise asymptomatic, but usually they have exertional dyspnea. But the most serious problem is the sudden development of cardiac arrhythmias, which may result in sudden cardiac death. One often hears the story that a child, apparently normal, went for a game or exercise and fell unconscious and died. Now, many of them have underlying this type of abnormality. Next one. Now, ECG can help in this situation because it can show the typical changes of hypertrophic obstructive cardiomyopathy, which are the deep symmetrical T wave inversions which may resemble old myocardial infarction. But if they are present in very young people without any history of previous pain or acute chest or heart attack or pain or a family history, then one should think of the possibility of a hypertrophic obstructive cardiomyopathy, and family history would support that. So that would be the pattern which should alert us to the possibility of this type of abnormality. Next one. Now the other syndrome, Brugadas syndrome, has become relatively more known these days because unlike in hypertrophic obstructive cardiomyopathy, where patients usually have some degree of left ventricular dysfunction and exertional dyspnea, here the children are usually quite normal until they suddenly develop a ventricular tachycardia which degenerates into ventricular fibrillation and very high incidence of sudden cardiac death. Now, the typical ECG in these people shows abnormalities in V1, V2 and sometimes in V3, which has a high takeoff of T wave. Now that is the typical abnormality. ST segment and T wave have got merged into each other. Now this is the normal tracing on the top. Now these changes in the right-sided chest lead V1, V2, V3 are the hallmark of this congenital condition. If detected, sudden death can be prevented in these individuals by giving them an implantable cardioversion device, ICD. Next. The second type of Brugadas syndrome is where the right bundle branch block pattern develops in the chest leads. Now here what we find is a broad QRS complex in V1, an RS and R1 pattern in V2. This is the feature of the right bundle branch block. It was regarded as a harmless congenital abnormalities in the past. But more and more evidence suggests that many of these people may have underlying serious disability which predisposes them to the development of sudden cardiac death from ventricular fibrillation. So people with this pattern in V1 and V2 should not be neglected. They should also be thoroughly evaluated for the possibility of serious arrhythmias developing, and if possible then one can prevent that by implantable cardioverter devices. Next one. Now, that's what we were talking about, the PVC and R on T phenomenon and leading to ventricular tachycardia. Here is the sinus rhythm, and a PVC occurs at the time of the T wave, and then that leads to the ventricular tachycardia. And if it progresses, it may result in ventricular fibrillation. And one can easily distinguish the ventricular tachycardia from the normal sinus rhythm. Next one. Now, other important arrhythmias which we can detect from the ECG are the supraventricular arrhythmias, particularly atrial fibrillation. Now, that's the normal sinus rhythm, regular RR waves, and here we find that the RR intervals are completely changing. Completely irregular RR intervals, and there is no P wave preceding any of these QRS complexes. So that's the typical appearance of atrial fibrillation. This is relatively less serious rhythm disturbance because atrial fibrillation, unless it is associated with some other cardiac abnormality, usually doesn't result in cardiovascular mortality. However, the chances of death from a cerebrovascular accidents from an embolic phenomenon are very high in these people with atrial fibrillation. So it's important to pick it up and treat it. Next one. Now that shows a relatively slow atrial fibrillation, which will not be detected by examining the pulse, because irregularity is not very marked. So person won't probably be able to detect it from the pulse, but the ECG clearly shows that the P waves are not present before the QRS complexes, and if you measure the intervals, you can easily see that they vary from each other. Next one. Now, another important abnormality which can lead to serious cardiac arrhythmias and sudden death is what is called a WPW syndrome, or Wolff-Parkinson-White syndrome. Now here the person, usually a young adolescent, they get repeated attacks of palpitations. And the reason for that is an abnormal communication between the atria and the ventricles, which bypasses the AV node, leading to more chances of very rapid impulses being conducted. And the ECG can give us a clue to this, because we find that in this type of phenomenon, we have a short PR interval and an extra wave between P and Q or R wave. That's called the delta wave, shown better here. That's the P. There is hardly any PR interval, and there is the delta wave and the R wave. So a short PR interval followed by an extra slanting P wave before the QRS complex, and the history of palpitations and cardiac arrhythmias suggests the presence of Wolff-Parkinson-White syndrome. That incidentally is just the presentation of long QT interval, which we already discussed. Here again you can see that the QT interval is prolonged, and here it is progressively prolonged under the influence of the drugs. Next one. Now WPW syndrome, because of this extra communication between the atria and the ventricles, which bypasses the AV node, there are more chances of ventricular arrhythmias developing. So we can have repeated attacks of ventricular tachycardia. The other important thing is that in Wolff-Parkinson-White syndrome, there may even be supraventricular tachycardias, but that will look like a ventricular tachycardia. Because of the abnormal communication, the QRS shape broadens and it looks like a broad QRS complex tachycardia, which is typical of a ventricular tachycardia. And this makes it difficult to distinguish ventricular tachycardia from supraventricular tachycardia unless we have previously known that the person has this delta waves present and a Wolff-Parkinson-White syndrome type of abnormality. Next one. The next serious cause of sudden cardiac deaths can be the heart block and Stokes Adams attacks, where we find that the sinus activity stops for some time, and if it is prolonged, it may result in sudden cardiac death. Here it is the abnormality in the impulse formation, and resulting in a sinoatrial block or sinoatrial arrest. The sinus stops producing the impulses, and the long pauses of silence, and that is the time, if it doesn't resume or doesn't start the heartbeat or not treated, can result in sudden cardiac death. Next one. Not only we can pick up the cardiac abnormalities from the ECG, we can also pick up the changes from various drugs in the toxicity in the ECG. A very commonly used drug is Digitalis, and its toxicity can be manifested by this type of change, which is couve plan depression of ST segment and T wave. Now this suggests that the drug being taken is reaching toxic levels, and stopping this would control the possibility that the person does not develop more serious cardiac arrhythmias later on. Next one. Now, hypokalemia is another important abnormality which we face in many situations. People who have had dehydration and not treated with proper fluids, people who are losing potassium because of diuretic therapy, which we so often use, people with hyperaldosteronism presenting as hypertension and having hypokalemia. So any of these situations where we find that hypokalemia is present is a very useful clue to the underlying abnormalities, and we can easily detect that in patients from an ECG. Of course, we can do the examination of the electrolytes, but ECG will also give a clue, and the clue is the inversion or flattening of the T waves and appearance of an extra wave, U wave, which is not very clear here, but I'll show you in the next slide. Next one. Now, that is the typical picture. The T waves are flattened and an extra wave appears before the next P wave. This is called the U wave. So flat T waves and U waves and eventually prolonged QRS complex indicates the possibility of hypokalemia. And this is as reliable as getting the electrolytes done, and it's more easily available on the bedside. Next one. Similarly, hyperkalemia, like in people who have renal failure, these days hyperkalemia is a problem when we are using ACE inhibitors and at the same time we are giving them potassium sparing diuretics like lasoride, or person being given other potassium supplements along with the ACE inhibitors. Very frequently encountered in the treatment of patients with hypertension. Now, if hyperkalemia develops, that can be fatal because that can also produce certain cardiac arrhythmias and certain cardiac death. And we can pick that up from this type of abnormality. You saw the T waves, they are usually more gentle in their curve. If they become sharp and pointed and tall, they're called the tall and tented T waves, and these are typical of hyperkalemia. And then we can look for the underlying cause and treat it. Next one. Similarly, hypocalcemia can also be detected from ECG tracing. This will produce an acquired QT interval prolongation. We discussed that many congenital conditions like Brugadas Syndrome are associated with a long QT interval, but if it is acquired, not present from birth, one of the likely possibility is the use of drugs which depress the ventricle like quinidine and procainamide, or it can also be hypocalcemia. Then the other signs of tetany would be present in these individuals. Similarly, a very short QT interval can also be a congenital abnormality, or it can develop as a result of hypercalcemia, like in a person with hyperparathyroidism or malignancy or any other metabolic disorders. Next one. And lastly, I mentioned that in the treatment of patients with the person who is having advanced cardiac life support, we mandatorily require ECG monitoring to detect what is the underlying rhythm disturbance and treat that. As I mentioned, in majority of the cases that would be a ventricular fibrillation, but sometimes what we find is that the ECG may appear to be quite normal. Here is a normal ECG, and yet the person had no cardiac beat or cardiac effective output. Now this condition is called electromechanical dissociation. So we should be aware of the pitfalls and deficiencies of the ECG interpretation, that ECG may be perfectly normal and yet a person may have a serious underlying disease. On the other hand, sometimes the changes are non-specific and one may misdiagnose disease. But in majority of the cases, even a simple interpretation of the general picture, the pattern of the ECG, give us a clue that underlying condition may require further evaluation. Next one. And that is the conclusion that if we want to avoid primum non nocere, that is no harm occurring in the patient, we should regard that ECG is a double-edged weapon. It can be very useful if used wisely, but one should not entirely depend on it. It must be correlated with the history and the other physical findings if one is to avoid the pitfalls. But it still remains that ECG is one of the investigations which should be available to most of the situations in general practice, because even with a very little experience, one can pick up very useful and important information which may suggest further need for evaluation. Thank you very much.